Hi, I'm Dr. Jordan Mandell, one of the residents here at NYU Langone Department of Ophthalmology, and we are here for an installment of NYU Langone's Department of Ophthalmology's collaboration with Ophthalmology Times for our journal club, where we sit down with some leaders in the field to discuss some of their recent work. Today I'm here with my faculty mentor, Dr. Ariana Levin, who is one of the glaucoma specialists here at NYU Langone, as well as our visiting professor, Dr. Anne Coleman, who visits us from UCLA, where she serves as the Bradley R. Stratzma Endowed Chair in Ophthalmology, the Chair and Executive Medical Director of the Department of Ophthalmology, and the Director of the UCLA Jules Stein Eye Institute, along as the Affiliation Chair of the Doheny Eye Institute. Today we're going to be talking about her recent work on the intersection between cardiovascular health and ophthalmology with her recent publication titled Cardiovascular Risk and Eye Health, a prospective cohort study of the Pooled Cohort Equations and Ocular Disease Index. Dr. Coleman, thank you so much for joining us today.
Well, thank you for having me. Really pleased to be here.
We were given the really interesting topic to discuss today, and I really wanted to just ask you first off, why did you choose this article for us to talk about today?
So I chose this article because, as you know, with your Master's of Public Health degree that you got when you were at University of Miami, that public health is really important for vision health. And I felt that this article really kind of shows how systemic diseases and eye health are interrelated. And also as a glaucoma specialist, Ariana, as you know, we have a hard time picking up those individuals who have glaucoma but are undiagnosed in the community. And so I really like this paper because it creates a screening tool potentially for us to find those individuals who have glaucoma but are unaware of it. Thirdly, I like it because the medical student, Fred's son, or Dayu's son, who's currently at UCLA, it was his idea. And so he really came to us with this idea and really did the analyses and really helped lead the efforts.
Those are really good points. It's nice that it's a big collaborative project, and it's always special when it starts off with a medical student. For listeners who may not use these cardiovascular risk scores a lot, would you be able to tell us about why you chose the specific pooled cohorts equation and what ophthalmologists may need to know about it?
So the pooled cohort equations were really developed by the American College of Cardiologists and also the American Health Association. So it's something that they developed to really help primary care physicians and cardiologists be able to predict in individuals ages 40 to 79 what their arteriosclerotic cardiovascular disease risk was. This information that's used to create the pooled cohort equations is really already available to physicians in the electronic health record. And so you can actually get that information and calculate the PCE, as they call it, that score, to really decide whether someone has low risk, borderline, intermediate, or high. And then based on that, be aware of what the risk of having glaucoma, AMD, retinal vein occlusions, diabetic retinopathy, and hypertensive retinopathy.
We know that some of these conditions already have associations with systemic disease, for example, vein occlusion and hypertension, or diabetic retinopathy and diabetes. How might the PCE inform us and guide us differently than our pre-existing knowledge of the individual systemic diseases with the eye conditions?
So for the ophthalmologist, it might not, but this is for the primary care physician so that they're aware that, wait a second, this individual not only has a risk of arteriosclerotic cardiovascular disease, but increased risk of age-related macular degeneration, for example. And that's not something that they're necessarily facile with in terms of knowing it. So
I know you mentioned previously the age cutoffs you used were from 40 to 79. Was there a specific reason that you guys chose that when we were looking at the subjects?
Because it was chosen by the American College of Cardiologists and the American Health Association, they were looking for individuals who are at risk of developing arteriosclerotic cardiovascular disease, and so they chose that age range. So that's why we chose that age range.
Okay, that makes sense, definitely, to model the same study the same way.
Could you also comment on the follow-up time? I think we follow the patients about 6 years in this study.
You want enough time to be able to follow them. We use the All of Us database, and so we chose 6 years. It does give the 10-year risk for arteriosclerotic cardiovascular disease, but we felt that 6 years was enough time, which was true because we were able to tell that there was increased risk of those eye diseases.
Some of the results that you report make a lot of sense, like AMD is higher risk as patients age. Were there results that surprised you?
The one that surprised me was the body mass index. I was surprised that body mass index was the same in all of us across all 4 risk categories. I thought that as your body mass index increased, you would be more likely to have a higher arteriosclerotic cardiovascular disease risk, along with the ocular diseases such as diabetic retinopathy, but we didn't see that.
I also noticed that too. It was very small range. I think it was 30 to 30.7, which I feel like is pretty negligible. I think it just shows us how multifactorial genetics and health and all these things are. Another thing that we definitely want to talk about is kind of we have this information of the study and we think about prevention and what we should do. If a primary care doctor sees an elevated PCE score or a patient in a high-risk group, what do the screening strategies look like in your ideal world?
So probably in the ideal world, they'd refer them to a provider to evaluate them. Because as we all know, a lot of times the screenings that we do, if you just use pressure, or even if you're just using the optic nerve, you can miss especially glaucoma. And so we would prefer exams.
Do you imagine that some of how this will be used will be integrated into primary care and screening offices where they also have fundus photography or other tools that are used for screening and referrals?
That's a great idea. It could be. We have at UCLA a lot of endocrine offices that have fundus imaging equipment, and then the photographs and imaging, digital images go to our retina practice, and they actually evaluate them. So it's a possibility, kind of depends on the PCP and the practice situation, but it's a good idea.
Yeah, I feel like it makes me think a little bit too about when patients are in our office and we already know that they're in the category of high risk. Should that make us have closer follow-up with them, or maybe do a little bit more extra imaging studies, maybe extra OCT here and there? Or should we just kind of say this patient has a normal exam at this time, despite their conditions? Should we maybe keep it at 1 year regardless for follow-up?
That tends to be what I would do, but that study hadn't been done. So that's a good question. I mean, I think that this is new information, and it might end up being that it's one of our risk factors because it actually is good at summarizing all of the systemic risks, and that can be very helpful. But that study needs to be done, so
Definitely.
I want to ask you about glaucoma. In the paper, you comment that as we look at risk factors and associations with glaucoma, there are other factors that are so important in glaucoma risk, perhaps eye pressure and cupping of the optic nerve, that maybe need to be integrated as we use these other risk factors to assess risk of glaucoma. So I wondered if you could comment on what you found or what your thoughts are on the findings of glaucoma in the paper.
yeah, so with glaucoma, it was just a moderate increased risk compared to like AMD and diabetic retinopathy. But we had to add in other ethnicities. If you remember on the paper, for the pooled cohort equations, they only compared blacks and whites. And it's really that other ethnicities and races are important, especially when you look at glaucoma. And so we wanted to make sure that was included. I think in terms of glaucoma, there's so many environmental and behavioral risk factors that we present and we're investigating, one such as sleep apnea. Maybe sleep apnea might modify that.
How do you counsel your patients who have sleep apnea, who also have glaucoma?
I counsel them to keep up with the treatment if that's what's recommended. I think, they've got new masks and everything. They're less obtrusive for those individuals. So I think it does help. And I think that's important. We're finding that even the circadian rhythm of sleep can be important in terms of potential glaucoma risks. So,
Can you give us an idea about what studies you have in mind to follow the results that are in this paper?
so the study would be to get the PCE on the electronic health record to be like an automatic score that shows up. Primary care doctor or the internist got that score, then they could start the referrals and we could see really how well it works, because a lot of this is done with the electronic medical records in All of Us database. And so it'd be good to have actual real world follow-up on it does it really make a difference in picking up those patients that are at risk for AMD, diabetic retinopathy, hypertensive retinopathy?
I think that's great, especially because a lot of patients in big academic medical centers get all of their care in one place. So it seems like it would be somewhat easy to include the PCE and all of their other visits and kind of use that information together to take the best care of the patients.
Yes, that's the idea. So, but that's really something that the cardiologists and the primary care physicians have to be interested in too. So,
I'm afraid that is all the time we have today. Thank you for being here, Dr. Coleman and Dr. Levin. Thank you for tuning into this collaboration between NYU Langone Health and Ophthalmology Times.